Ladies and gentlemen, you are welcome to this day of lung science presentation in July 2023. I welcome the audience from wherever you are, both near and far, Uganda and elsewhere. We are looking at a topic of silicosis as a growing problem in Uganda's nascent mining sector. What brings us to this point? Why do we need to talk about this? Let me first introduce myself. I'm Dr. Deogratius Sekimpi, who is an occupational physician, a graduate of Makerere University many years ago, but also of London School of Hygiene and the Dundee University for Occupational Health. And I also hold a fellowship of the Faculty of Occupational Medicine of the Royal College of Physicians of Ireland. So I've been a practicing occupational physician for quite a number of years. But the issue of the lung diseases has been somehow dear to me, in that while I was doing my master's degree, I found the issue of occupational lung disease pertinent, particularly because of occupational allergy. And shortly after my graduation at London School of Hygiene, we did a study in Uganda on occupational airways disease, which was particularly on coffee allergy. As an occupational physician, I've continued to see a number of cases with occupational lung diseases, unfortunately, mainly for assessment of compensation, which is unfortunate on my part. But with the Dr. Worodria and others who are more active in the care side, I think they may be having more satisfying results. In terms of history, silicosis, as you can imagine, is from silica. And you remember that we had a Stone Age where people were using stones as their main instruments of day-to-day living. One would imagine there could have been silicosis at that stage. Later on, we had the Iron Age, where people started making spears and other tools from metal. And of course, it meant they had to get ore somewhere. So chances are that silicosis was present at that time because most of the minerals would have silica. Now, as the Industrial Revolution came and other metals had to be made, steel and so on, still there must have been a lot of use of minerals and leading to silicosis. Even Bernardino Ramazzini talks about diseases due to silica. But specifically, sometime later, the mining sector has grown by leaps and bounds, and Uganda has found itself in that fray as well. So specifically in Uganda, we would have stone quarrying because we have a booming construction sector recently, and we use a lot of stones. People crush stones, and the men and women working in those quarries get exposed to silica, and considerably many get silicosis. However, more significantly, recently, Uganda has developed the gold sector, and we have both large-scale and small-scale gold mining. And for some reason, UNACO, of which I'm part, was has been involved in working on elimination of mercury in gold mining. However, along the way, we have also noted that as more and more people go into mining, large scale, but more so in the small scale, a lot of lung disease is coming as a result of silicosis. So last year, we had two significant events. One was a grand round on silicosis organized by Dr. Worodria and his team. But also we had a mini OSH conference alongside the Makerere UNACO joint conference, which is called JASH, in which the rest of the world under the International Commission on Occupational Health discussed health and safety in mining, and the silicosis came up as one of the major areas. Because of that, we have been developing a team, a multi-sectoral team, to look at silicosis and other lung diseases in mining and other occupational hazards in mining, but with silicosis in the lead. And Dr. Worodria, William, will this afternoon discuss with us about this and other areas in some detail about this problem of silicosis as a growing concern. Dr. Worodria is a consultant pulmonologist, a physician, a senior consultant physician in pulmonology, and he's also a senior fellow, EDCTP fellow at IDI in Uganda Infectious Disease Institute, and he's an adjunct assistant professor at the Case Western Reserve University, and also an honorary professor of medicine at Makerere College of Health Sciences. So he has got many years of experience in lung diseases and done a lot of research. So today we are privileged that Dr. William Worodria can be able to take us on this subject of silicosis, particularly in the mining sector in Uganda. Dr. Worodria.
Thank you, Dr. Sekimpi, for the very kind introduction. I will share my slides. I hope it is visible.
Yes, it is.
Thank you. So our topic for the Day of Lung Science looks at silicosis, a growing problem in the Ugandan nascent, actually economic sector, because, thank you for that kind introduction, Dr. Sekimpi. There is nobody more experienced to talk about occupational health than you, because I know you've been involved in that area for several decades. So it's really an honor to share this space with you, talk about a topic of great interest. And that in brief is the outline of the presentation, in which I hope to contextualize the issue of silicosis, and I will share some preliminary findings of operational studies we've done in the clinical setting. Silicosis, in brief, is an irreversible fibrotic disease of the lung, explicitly caused by inhalation of respirable crystalline silicon dioxide. The Earth's crust, which is a depth of about 20 kilometers from the Earth's surface, is largely composed of silica. About 60% of the Earth's crust is made of silica. So silicon dioxide is abundant in the atmosphere. But we are talking about it in the context of occupation, and a review in the BMJ looked at least 17 years of pneumoconiosis, and they noticed an increase by about 66%. And of this, in that particular year, 20,000 were cases of silicosis. And in Africa, where there's actually little data, silicosis still accounted for the majority of the cases of pneumoconiosis. And that showed an increase of greater than 100%. So there's still inadequate knowledge on the burden of silicosis in our settings. It is known that crystalline silica, which is called quartz, is the most toxic form of silica. There are other forms like the amorphous silica, which may lead to lung fibrosis, but quartz is the most toxic form. Silica as well is a human carcinogen, according to the International Association of Research on Cancers. So it's a class 1 category, which means there's a definite association with cancer. And importantly, there is a clear exposure response demonstrated for silicosis and mortality. So the more silica you're exposed to, the more you are at risk of death. Unfortunately, the disease is progressive and almost always fatal. There's a close association with tuberculosis, and unfortunately, no specific treatment exists. Several treatments are tried, but there's no specific treatment. So it makes the role of Dr. Sekimpi and others very relevant. And not only him, of course, each of us in our various settings, we need to be cognizant of this. This pot from a pathology museum somewhere in Spain shows you the extent of lung damage that may arise as a result of silicosis. You see a lung full of silicotic nodules and a large upper zone cavity as a result of tuberculosis and silicosis. Would like to give you the historical perspective. Silicosis is a disease of antiquity. And the father of medicine, Hippocrates, 5 centuries before Christ, described a condition of breathlessness among miners. Agricole, who is known as the father of mineralogy, provided the state-of-the-art blueprint, which was used for at least 2 centuries on mining. And in it, we will look in more detail about some aspects that he pointed out. And Ramazani, that Dr. Sekimpi mentioned, described silicosis nodules in postmortems of stone cutters in the 17th century. And the name silicosis was coined by a pulmonologist called Visconti in about the 19th century. So it has been a disease that has been with us. And Georges Andreas Agricola, who is called the father of mineralogy, he wrote a document called De Re Metallica, which is a dissertation of sorts on mining and smelting. And many of the terminologies he introduced are still in use today. In it, they tell you how to identify ores, how to identify mines, how to locate mines, the tools to use in mining, the machinery, and how to refine and smelt minerals. So he was way ahead of his time. And the English translation of that document was by the 31st president of the United States, called Herbert Hoover, who was an engineer, actually, and his wife, who was a geologist. So it is a document which is really the Bible of sorts for the mining community. And he did state in that document that mining and prospecting were not a matter of luck and hard work, but they needed specific, specialized knowledge. With regard to health, at that time already he noted the issue of dust with the lung. Dust penetrates into the windpipe and produces difficulty in breathing. And in another part, he notes that if the dust has corrosive qualities, it eats away at the lungs and implants consumption, which is an old name of tuberculosis in the body. He also reports a situation where there were women who married up to 7 husbands, all of whom the terrible consumption carried to a premature death. So young men died early as a result of mining-associated activities. Come to think of it, this was probably the reference the Sadducees had when they were asking Jesus about marriage after death, where they said a woman married 7 brothers and all of them died, one after another. At the resurrection, whose wife will she be? So I think it had something to do with this. So Bernardino Ramazzani is referred to as the father of occupational health. And as a medical student, he interested himself in the complications of work-related diseases. So he outlined hazards of chemicals, dust, metals, even violent motions and odd postures at work. His significant contribution was to introduce an important question for us medics to ask patients or clients: where do you work? And for us pulmonologists, that's a very critical key because it can explain the malady you're suffering from. Silicosis, we said it is dose dependent on the amount of dust you inhale. And these dust particles are ingested by macrophages. This leads to lysosomal damage, releasing products of inflammation. And this leads to lung fibrosis and also inflammation. So the more exposure to dust you have, the more inflammation and the higher the chances of fibrosis. And there are a few types. There is what you call simple silicosis, where somebody may have nodules, usually in the upper zones of the lungs, and the dry cough or dyspnea. Or they may have complicated silicosis, where they have more nodules and more fibrosis. The worst case scenario is when they develop progressive massive fibrosis, where there's continuous fibrosis and destruction of the mediastinal structures. Many of these patients end up with pneumothoraces with the pulmonary hypertension as a result of copulmonale, and usually the prognosis is not very good. In addition, there's what we call accelerated silicosis, which has a short latency and usually is related to in high exposure to respiratory crystalline silica. I will just browse through briefly about the mining. I think Dr. Sekimpi did mention the issue of Uganda's wealth gifted by nature, and you'll see all sorts of mineral deposits. And in particular, gold is indeed one of the most treasured minerals. And there are 4 main centers in the country where largely the activity is informal by small groups called artisanal miners, and sometimes difficult to regulate. A few of them with support are being formed into organizations where they can have better security to the rights of mining. You've heard of newspaper reports where 60,000 or so people were evicted from Mubende because largely these were artisanal miners. So if they form association, they have a better chance, and probably we have a better chance of regulating the activities. And they're usually associated with marked gender inequalities, which are also a big problem. So about 400,000 artisanal miners, and they mentioned already the risks associated with mercury. However, minimal sensitization has been done regarding lung complications like silicosis. Permit me to touch some similar economic activities. Mining is the big item. However, construction industry, there's a deficit of knowledge regarding complications of working in this industry. And it's very important because Uganda has a large housing deficit, which is growing annually. And yet literature about safety in the construction industry is very minimal. They only reports about injury, which is an important one, but some of the health complications associated with construction industry are not elaborated. One last issue to talk about is artificial stone silicosis. Many of us have places of abode, and they're beautified with the artificial stone, like this kitchen bench top or table and the walls. However, these are made out of stone, which are reconstituted using a resin and are molded into slabs and heated. But in fact, the silica content in these artificial stones is very high compared to the natural stone. And in one report of 7 patients with artificial stone-related silicosis, 6 out of 7 had the severe form of silicosis. It is progressive massive fibrosis. And in a related study in the south of Spain, out of 100 patients diagnosed with artificial stone silicosis, 93% had simple silicosis at diagnosis. And when they were diagnosed with silicosis, they stopped working in the stone industry. However, 4 years down the road, of these people with simple silicosis, many had progressed to progressive massive fibrosis, up to about 40%. So this artificial stone is a big problem. And because of probably the amount of dust in the concentration of silica, it kind of rapidly leads to worsening fibrosis and poor outcomes. So I will just share with you briefly our observations on the pulmonology unit at Mulago. Since 2021, after the post-COVID time, we came to notice that several patients come in with severe lung fibrosis, and these people were really not going away. And we did observe many were actually coming from Mubende, which was one of the main gold sites. So we decided just to collect some basic operational information about them. And these are really preliminary findings. So there was limited information on silicosis, and we noted that there's an increase in the economic activities that predispose people to lung injury. So this was kind of the basis. And these individuals spent long on the ward and many times did actually not survive because they needed long-term oxygen use and they could not even afford oxygen. So we wanted to describe the characteristics of these patients with silicosis over a 1-year period and describe what the impact of silicosis was in these patients. So we collected a few information of their demographics, exposure, time from symptom onset to diagnosis, and their knowledge about silicosis, whether they used protective equipment or not. And yeah, silicosis was diagnosed clinically based on history and also radiology. So we had 17 participants with a median age of 42, which is really the active, productive age group. And most of them were male, and a quarter of them were smokers. Median duration of symptoms before diagnosis was 6 months. And they had been hospitalized at least 2 times before admission at Mulago. One particular participant had been in hospital for at least 12 times before this hospitalization. And the median duration of hospitalization here was 6 months. 3 months. So you imagine 17 participants on a 24-bed unit being hospitalized at least for 3 months. So you can assess the bed occupancy of these individuals because they're not getting better, and yet you cannot discharge them because they cannot afford oxygen. So it's quite a dilemma. So the occupations, majority belong to the gold mining industry. 7 out of the 17 are gold miners. And it's similar, 7 out of 17 were in the construction industry. One farmer and one was a casual laborer. You will see where silicosis comes into the picture. And you will note that 2 were stone cutters. So this probably either people breaking stone, but I think at least 2 of them were tile cutters. So which falls in the category of artificial silicosis. Yeah. So the symptom profile, most common symptoms were cough and difficulty in breathing. A few had other symptoms of chest pain and hemoptysis. And we have a few illustrations, like this X-ray belongs to a 42-year-old male who had been a painter for 17 years. He came with a history of shortness of breath for 2 years. And he actually has been hospitalized for the last 18 months, partly social reasons, but also failure to afford oxygen. So that is one bed less, but, of course, you're not going anywhere. So he had basically ground glass infiltrates with cystic lesions. And we know that painters, before painting, they do brushing of the walls before applying the paint. So, and a lot of that material is rich in silica. That could be the source of thing. The second patient was a 27-year-old casual laborer. He worked in a hardware shop. And he had been diagnosed with TB. As you can see, he had cavitary disease, but he noticed despite TB treatment, he did not improve. So he had had cough, difficulty in breathing, and weight loss. And that's what brought him to hospital. So again, this was probably, he was involved in loading and offloading of cement, and that probably was the source of his silicosis. And the last illustration, this was a 47-year-old male who worked with a gold mine for about 3 years. And what you are seeing is really coalescing of the fibrosis with traction of the mediastinum. So this is what you call progressive massive fibrosis. So if you are talking of other organs, this would be more or less like end organ lung disease, which is the worst case scenario for silicosis. So I just picked some images to illustrate the mix of patients who are admitted with silicosis. Importantly, most of the patients could not afford home oxygen. And trying to ask the impact of the illness on their life, most of them were concerned that they were not able to support their families or even support themselves. So they were really incapacitated. One person had to sell most of his property to try and access care. Several had children who they could not afford to pay school fees for. And one felt physically disabled, and a couple of unable to leave hospital. So from these brief facts, we know that most patients hospitalized with silicosis present with advanced complicated silicosis and are in need of long-term oxygen therapy, largely as a palliative measure. And gold mining and construction seems to be the commonest economic activities linked with silicosis. And more importantly, there is a delay in diagnosis of silicosis. Probably if many of these are picked early in the simple silicosis, they can be counseled to change occupation and probably live with some minimal damage, but they come with advanced lung disease and you cannot do a lot. So, and most participants were not able to afford long-term oxygen therapy and hence had to stay in hospital for long periods. So in conclusion, silicosis is an important cause of catastrophic health expenditure and chronic morbidity among economically productive adults in Uganda. And there's a knowledge gap probably on the risk factors and the prevention of pneumoconiosis, which explains the late presentation, the late diagnosis. And the cost of long-term oxygen is prohibitive. So leading to long-term hospitalization. So we recommend an urgent need to address this problem through early detection, preventive measures, but also there should be provision for rehabilitation for people who need this service, who already are ill. And funding for long-term oxygen in other settings with functional insurance systems, usually it's handled by the insurance, in other words, so it may be too expensive for individuals to handle. So I thank my colleagues and the institutions above and several of my interns then who were able to contribute to assembling this information. So Chair, I think I will stop here at this point in time and I will be ready to take any questions.
Hey, thank you very much, Dr. Worodria, for the presentation. Members, we have had the expose about this problem. Gold mining is one of the main causes, or one of the occupations where which are affected, but we have seen also other areas, particularly in construction, but also in other casual work, as you heard. So one needs to look out for these sort of situations so that something could be done. Now, I will open the discussion to members. I don't know how those who would like to ask questions or to make comments can raise their hands, and we give them an opportunity for at least the next 15 or so minutes. Do we have any hand up? Yes, Josephat, you can unmute. Josephat Baluku rather, Joseph Baluku.
Thank you, Professor Worodria, for the excellent presentation. It's always nice to listen to you. I saw a very nice elaborate pathophysiology there, and therefore my question comes, are there any studies that you know of that are developing treatments targeting those sites? Because clearly once someone has this silicosis, many of us in the practice can only keep them around on the ward up to the end. But now that the mechanisms are known, I don't know if you have any knowledge of clinical trials that are ongoing where they are trialing out some of these agents. Thank you.
Thank you, Dr. Baluku. As always, yeah, I think that's an interesting question. Yes, I did see several attempts to treat, to conduct some studies, but there were far few in between because one, we do know prevention is the best form of therapy in this instance. And the ethics would certainly present some challenges unless you pick people with the minimal silicosis or simple silicosis. But then at that time, you will be obliged to inform them about the occupation. So actually, silicosis in the West had largely declined because of the environmental measures. However, when they got these artificial silicosis products, then without knowing, we had epidemics of silicosis exposure. So the issue is the trials, we know the pathway. The issue is where will we do the enrollment of these study participants? But there were candidates they talked about, and also some measured included the use of the antifibrotics, that the pirfenidone nintedanib in certain instances had been shown to be beneficial, and also whole lung lavage, assuming people were exposed to massive catastrophes like maybe the Twin Tower collapse, or maybe the bombing of the US Embassy in Nairobi at that time, and exposed to so much silica inhalation, I would imagine whole lung lavage would make a difference early on. So Dr. Waluko, in a roundabout way, yes, we know what might work, but the issue is this something we can do in a clinical trial setting? And will the ethics be appropriate to be able to see us through to develop these candidates? So many people tend to apply knowledge already acquired. Thank you.
Somebody is asking, I don't see the name, from the chemical nature of silica, does it cause an acute inflammatory response, a chronic irritant, then fibrotic tendency to the lung parenchyma?
Yes, that is, I think, Peter Semfuka. Yes, that's an interesting question. And from the cartoon I showed, it causes rupture of the macrophage. Of course, the lysozymes releasing inflammatory products which give rise to those reactive oxygen, reactive nitrogen species, which prolong the fibrosis and inflammation. I would say it is both, and it depends on the level of exposure. The more silica you're exposed to, the more severe the inflammation. Prior to these artificial silica products, silicosis was known more of as a chronic disease, would last 10 to 20 years. And many people would develop silicosis long after they have retired from their job. But now with machines which produce aerosols, like these fast drilling machines, which generates large volumes of aerosols, I think the exposure is massive and the inflammation is similarly substantial. Thank you.
Yeah, there is somebody also asking about how helpful to wear particulate respirator mask.
That's maybe a good one. That is a good one. Of course, thanks to COVID, we have used this kind of respirator, but I think Dr. Sekimpi, you are probably best suited to answer this one because the terrain in the mines and wherever is a little bit different. You imagine you are maybe 30 meters underground in a narrow tunnel trying to drill for gold. And then you have an N95, unless you have an oxygen cylinder. So the handbook of mineralogy talks about ventilation. The trouble is we are dealing with artisanal miner who may not have resources to ensure adequate ventilation. Theoretically, yes, probably on the outside, but you would need industrial N95s or N99 or whatever to provide protection. So yes, it is important. That's part of the thing. The other measures include using water kind of to limit the aerosols. So you end up with a sludge instead of dust in the atmosphere. That helps to minimize it. But there are several other ways around this which need to be explored in the mining sector. But as we said, it's probably when these people get organized that such measures can be implemented systematically.
Okay, I can add something about this.
Yes.
Yeah, so there are maybe two factors: the DOLS, which affect the DOLS, which affect the human being. One is the size of the particles, because it is not all the particles that are a problem. It is the air, respirable, those which can reach their alveolus. So they must be very small. So the big one, actually the dust you don't see is not a problem. It is the dust that you don't see that is the problem, because that is the one which is going to reach the alveolus and is the one which will be picked up by the macrophages and so on, and then you get the problem. So I imagine by what William has mentioned about if the one could moisturize the air in the mine or wherever there is the dust, so that those particles can settle, you might be able not to get, to reduce the exposure. Then the ventilation, because the ventilation, of course, is very important, but as mentioned, the tunnels are very long, many miles and so on. So even if you will find that the person who is like at what they call the seam, where the mining is actually taking, the drilling will be in a form of an enclosed space. What do you call it? Confined space, because it is him or her and the surface, the face where they are doing the drilling. So the dose becomes very high. So the masks could be helpful. And in the masks, use of masks, there's what is called a nominal protection factor. Because something, when they say N95, what does it mean? It means the concentration inside the mask is 1/20th. 5% is outside. It can, if you have 100% something concentration, inside will be only 5. So the protection factor is 95. So if it is particulate, so that is the N95. But now, how much is that 5%? If that 5% is also very, very high, is almost equivalent to not protecting. So that's why maybe if it were actually workable, one would say you would use that oxygen cylinder and so on. But the temperature, when you are down there for so many hours, under those conditions, how many cylinders will you carry? Unless there is a line of oxygen from outside to that. So that engineering bit, I think as we say, we may need to look into it, what actually happens right now in other countries and what can happen here. Because somebody was saying, can we do some studies? Maybe the group which I was talking about, which we are trying to look at, would be going into such things as we go along for various situations. Because when people are outside, it is a lot easier to protect than when people are in the mine in a tunnel. Yeah, I don't know whether I have made some clarification. I hope I haven't confused what I said.
Thank you, Chair. And in the chat, I see Dr. Stavia is requesting for a more elaborate study. Indeed, I think that's important, which can inform policy. And I'm glad as the head of the TB unit, she's on, because silicosis and TB go neck to neck. So that is definitely important. Tony talks about compensation. How does a pulmonologist contribute to help in calculating compensation? Well, one, I think you need to have kind of guidelines in that direction, and probably Dr. Sekimpi has been doing that for a living for a long time. You might actually be in the best position. But as we said,
we have lost you.
Sorry, I think I was muted. Sorry. I don't know where you last heard me.
We are talking about the compensation.
Yes, compensation, I think, is too little, too late. Maybe Dr. Sekimpi, you might have a better idea, because you need
Elaborate about it.
You need a regulatory framework to guide this compensation. But what compensation is really adequate when you have lost all your lungs? Basically, it's really, yeah. So I think maybe you will compare.
Can I make a comment on that?
Yes. That's.
I think now with the presentations we have, one would be giving 100% because somebody cannot work again. And you know, these are issues which are usually taking people to court, not particularly for the miners, but when they see somebody walking and you are saying this person should get 100%, they say, but how can somebody have 100% when he's walking? But the important thing would be, in other countries, they have what is called a pneumoconiosis board, and the miners are regularly examined so that, okay, not as soon as the profusion becomes more than significant, and that one is also difficult to cut off, they do serial x-rays, chest x-rays, and when the profusion is becoming much, they must be stopped and they get compensated. And this is usually through insurance by companies, or in some cases by governments. Like we had somebody who came from India and talked to us. In their states, the government compensates anybody who gets the earliest signs of silicosis. So in this country, now that mining is becoming a lot more significant, that is one of the areas which we'd be trying to look at. How do we deal with these people?
Thank you.
As early as possible.
Thank you, Chair. And I think that answers Dr. Mtuire's question about early detection. there are no very good tools for early detection, but spirometry probably would help you. Unfortunately, X-ray is the main tool recommended by the International Labour Organization, which is not very sensitive. One study showed that 43% of people who are termed normal on chest X-ray had actually evidence of silicosis on CT scan. But when you talk about CT scans, you talk about radiation, you talk about the cost implications, and for use on a programmatic level, it may be a bit challenging. Yeah, thank you very much. Yeah.
Yeah, we have a few moments. Are there any other reactions? There was something about treatment here, which I can't. I don't know why I'm not able to read properly. From Natasha. No, sorry, Shahista. Can you read that one? Okay, this is a journalist, I think. So, Dr. Worodria, they want your contact?
Okay, I'll provide it. Yeah, that's okay. I think.
Yes, sir.
Yeah.
Okay. So, any other reactions? We just have a few more minutes to the hour. They would also like to share the presentation. That is your
That is okay. I'll make it available to the MLI liaison person who should be able to share. Yeah.
Okay, so you said thank you. Any other treatments apart from oxygen? I think there was a mention about antifibrotics and whole lung lavage, unless the doctor you're adding something else.
Yes, of course, the ultimate treatment may be lung transplantation in some. Of course, the 3-year survival after lung transplantation is about 75%. No center in the region does that. So one, of course, we are talking about the organ donor policies. So for the lung, I think it's a little bit distant yet, probably easier with the kidneys. So I think lung transplantation is some, yeah. But of course, there's a lot we do with the palliative care team, with the physiotherapy team. You support them through their distress, and really that is what we can offer. Symptomatic treatment.
Yes, so there was something which I needed to mention. Maybe it didn't come out very well so far. And Dr. Stavi, I think he should listen to this a bit specifically, because what we are having among the miners, particularly the gold miners, we have silicosis, which predisposes to TB. But in the settings which we have in the mining villages, we also have a lot of HIV. So we have got a triad of TB, whose commonest comorbidity is HIV. And the second comorbidity of TB is silicosis. So which means when you have that combination, one would want even to find out how those three comorbidities affect each other. So when we are looking at the study, and Dr. Stavi, I think in this initiative which we are trying to undertake, would be very much interested to be involved with the TB program, so that we could see how we look at this triad, which is, in my opinion, very vicious. And one would want to look at it holistically from those 3 points of view. Somebody was talking about Buhweju. Not yet at that study, I think. And the Stavia says available for the study. So we are going to, we shall talk more, actually through William. I think he has interacted with you a bit more. And it is now 4 o'clock. Could we be winding up? Unless there is something very burning. William, is it okay if we can wind up now?
Yes, I think I do not have anything to add, Chair. But I thank the participants for actively engaging the meeting.
So ladies and gentlemen, this has been it has been a pleasure for us to be part of this discussion. It is opening a Pandora box, which as health professionals, we should just be we should be reacting positively to try and find solutions. They may not be easy, but we must try. And from the discussion, prevention is better than cure. So we need to look at preventive aspects. We also need to look at the clinical aspects, the treatment. How can we get people to early treatment? How do we maybe change people's jobs and so on? And of course, there has been the issue of rehabilitation and the compensation. Now, when one is self-employed, who compensates them? Maybe one would say if the country is benefiting from them, that's why in other countries, the state takes over the issue of the compensation. So we have had quite a number of ideas coming up, a lot of expose and a lot of ideas coming up, and now we look forward to progressing this to next level of action. And those of us who are already in this mini consortium, and not consortium, it is a working group. We would want to see how we move forward to try and protect this subsector, which is so of growing importance to the Ugandan economy, and I think also internationally. Thank you very much, and goodbye.
Thank you and bye.